Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Okay, let's unpack this. Today, we're diving deep into a classification system that is absolutely vital for anyone involved in surgical practice, particularly in hepatobiliary and general surgery. We're talking about the Strasberg classification of bile duct injuries.
Right. A really crucial framework.
Absolutely. Our mission here isn't just about, memorizing types. It's about truly unlocking the power of this system, seeing it as the master key to understanding and solving the complex puzzle of bile duct injuries.
Yeah.
Think of it as your essential forensic guide, kind of revealing hidden dangers and clear pathways to patient recovery. You're about to get a shortcut to being truly well-informed on this critical topic.
And what's fascinating here, I think, is how the Strasberg classification has really evolved into the universal language for describing these injuries, especially, with lap coal being so common now.
Laparoscopic cholecystectomy, yeah.
Exactly. These injuries, they're relatively rare, thankfully, but they carry just immensely severe consequences when they do happen. We're talking about the potential for debilitating infection, persistent bile leaks that just wreak havoc, chronic biliary strictures.
Yeah, nasty stuff.
Secondary cirrhosis, even liver failure down the line. So a clear, universally understood classification like Strasberg is just paramount. It's critical for both immediate and, importantly, long-term therapeutic planning for our patients. It literally sets the stage for everything that follows.
So where did this incredibly detailed system actually come from? The Strasberg classification, it didn't just appear out of thin air. Right.
No, not at all.
Yeah.
It's really an evolution of earlier attempts. People might remember the bismuth classification, for example.
Right.
Strasberg built on that. It adds crucial categories to capture a much broader and, frankly, far more nuanced range of injuries that bismuth didn't fully cover.
It's like going from, a basic map to a full-on GPS system for the biliary tree.
That's a great analogy. Exactly. It moves beyond just the obvious, the big major duct injuries, and strategically incorporates those more subtle yet equally problematic issues. So our goal today is really to guide you through this hierarchy, focusing not just on definitions, but on the underlying pathophysiology, the typical clinical presentations you'll actually encounter. And most critically, the direct implications for you, the surgeon, in your daily clinical practice. What does this mean when you're faced with it?
Okay, let's kick things off with type A bile leak from a cystic duct stump or small ducts. Now, when we hear type A, it sounds like the first, maybe the simplest category. But what exactly defines it, and what's the key clinical takeaway for surgeons?
Right. Okay. So by definition, type A involves injury to minor ducts, specifically the cystic duct stump, which is a very common site for small leaks after a cholecystectomy, or these accessory bile ducts like the ducts of Luschka.
Luschka ducts, always tricky.
Always tricky. They're particularly interesting because they drain segments of the liver directly into the gallbladder fossa, and they can be notoriously difficult to even see during surgery.
Right.
Clinically, patients with type A injuries, they often present with postoperative bile leakage into the peritoneal cavity. Now, this can manifest as anything from, say, mild abdominal pain to fever or even localized peritonitis. It really depends on the volume and how long the leak's been going on.
Okay.
The prognosis for type A is generally considered minor compared to the other types. We can often manage these non-operatively.
So no immediate rush back to the OR necessarily?
Not always. Often we use ERCP, endoscopic retrograde cholangiopancreatography. That's where we use a scope, go down, and we can do some sphincterotomy.
Right, cut the sphincter muscle a bit.
Exactly. Just a tiny cut to help the bile flow better down the main duct, or we can place a stent across the sphincter or even up into the duct. This reduces the pressure inside the duct system and allows that small leak from the cystic duct or Luschka duct to heal and close on its own. Most patients recover quite well with this kind of conservative or minimally invasive therapy.
Okay, that makes sense.
Yeah.
But it's tempting to think of type A as just minor, right? But you mentioned earlier the real insight here, maybe a common trap for clinicians, is underestimating its potential to escalate silently. What's the biggest misconception surgeons might have about these small leaks that could lead to significant problems if not caught early?
Precisely. That's the key danger. The hidden danger isn't the leak itself necessarily, but the delay in recognizing its potential.
Yeah.
It can become a breeding ground for infection, forming an abscess or causing a persistent biliary fistula. A seemingly trivial leak, if it's just left unaddressed, can spiral. It can turn into a much more complex septic picture later on, which ultimately just prolongs the hospital stay and it increases patient discomfort and morbidity. It really teaches us vigilance, even for what seems like the smallest injury.
Vigilance.
Yeah.
Okay, so if type A is about a leak, then type B introduces a completely different kind of challenge, an occlusion, a blockage.
Yes.
Can you walk us through how this blockage typically presents and maybe why it's so often a delayed diagnosis for us?
Absolutely. Type B is defined as an occlusion of the biliary tree, and it almost invariably involves an aberrant right hepatic duct. That's the key anatomical feature here.
Aberrant, meaning not where you'd expect it.
Exactly, not the standard textbook anatomy. The injury is usually an accidental ligation or clipping of this unexpected or aberrant right hepatic duct. This leads to segmental biliary obstruction, so only a part of the liver is blocked. These aberrant ducts are anatomical variants, and if they're not meticulously identified during dissection, they are just prime candidates for injury. The clinical implications for type B are indeed distinct and often quite insidious, as you said. Patients frequently present late.
How late are we talking?
Sometimes weeks or even months after the initial surgery. They might come in with subtle features of cholangitis, but affecting only that specific segment of the liver, or even present with segmental liver atrophy because of that chronic obstruction.
Wow, atrophy, so permanent damage.
Potentially, yes. And this delayed presentation happens precisely because the obstruction is segmental. It doesn't involve the entire biliary tree, so you don't always get that classic generalized jaundice as the initial red flag.
Makes sense. So what's the treatment approach?
Well, surgical intervention is almost always required here to restore bile drainage to that affected liver segment. The techniques might include a hepaticogeostomy.
The bypass again?
Yes, connecting the bile duct directly to the jejunum to reestablish flow. Or, unfortunately, in cases where there are irreversible changes and significant fibrosis in that segment, a segmental liver resection might be necessary. The critical takeaway here for type B is that a delay in recognition can lead to significant chronic morbidity that's much, much harder to address successfully later on.
That delayed presentation for type B, it really does sound like a potential nightmare for both the patient and the surgeon. Have you found that this specific type is maybe the one most likely to catch even experienced surgeons off guard because of that tricky variant anatomy? It feels like it requires a real detective's eye in the OR.
It absolutely does.
Yeah.
Type B truly highlights the critical importance of recognizing anatomical variants in the operating field. While we always preach meticulous dissection and constant awareness,
Sure.
these aberrant ducts can be deceptively small or maybe positioned unexpectedly, making them easy to injure if you're not specifically looking for them or aware of the possibility.
So maybe more proactive imaging beforehand.
Exactly. Preoperative imaging, like an MRCP, can be invaluable in mapping out these unique anatomies, especially in cases you might deem high risk for whatever reason. It gives you a heads up.
Okay, so let's zero in on the subtle but really critical difference between type B and type C, because you mentioned both involve aberrant anatomy, those unexpected ducts.
Right.
Type B is about a blocked duct, essentially ligated or clipped shut. Type C, though, is a cut duct, but it's left open to leak. How does that fundamental difference change the surgeon's immediate response?
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
That's precisely the distinction you need to internalize as a surgeon. Type C is a complete cut, a transection of an accessory hepatic duct. Commonly, it's the right posterior sectoral duct, which causes a persistent bile leak, but notably without ligation. The duct is open and actively leaking bile.
Okay, so an open pipe, essentially.
Pretty much. Clinically, type C presents, as you'd expect, a persistent postoperative bile leak. You might see it coming out of surgical drains, or it could lead to delayed abdominal symptoms because a biloma, a collection of bile, is forming, or even bile peritonitis.
And the management. Still ERCP sometimes.
Management often begins with endoscopic or percutaneous interventions, yes. You might try ERCP with stenting again, or place an external drain percutaneously to manage the collection and control the leak initially. However, if these conservative measures fail to seal the leak, then surgical repair, often involving some form of biliary reconstruction, is usually necessary.
And the outcome?
The outcome here really underscores that early identification is crucial for preserving the function of that liver segment. Delayed treatment predisposes the patient to ongoing infection, abscess formation, and potential secondary injury to the liver parenchyma itself. It can turn into a much more complex problem, potentially causing lasting liver damage if not addressed promptly.
Okay, moving on. Next up is type D lateral injury to a major bile duct. So this isn't a full transection, not a complete cut, but a partial injury. What are the clinical signs you're looking for here, and what's the sort of long-term lurking danger with these partial injuries?
Right. Type D is defined as a partial thickness injury to one of the major ducts, the common bile duct or the common hepatic duct. Think of it like a lateral tear or maybe a significant scrape or a gouge from an instrument rather than a clean cut all the way through.
Got it. Partial thickness.
Exactly. Clinically, these patients may develop an ongoing bile leakage, similar to type A or C initially, or perhaps a subhepatic bile collection. But the real insidious danger here, if it's left untreated or isn't recognized fully, is that the partial injury site can heal with fibrosis, and that leads to a biliary stricture.
The stricture risk again?
Yes. For treatment, sometimes very minor type D injuries, if recognized immediately, can potentially be managed conservatively by placing a T-tube through the injury site or an internal stent across the injured segment to promote healing over that scaffold and provide drainage.
But if it's missed?
But, and this is the crucial part, delayed recognition significantly increases the risk of that insidious stricture formation down the line, which then almost always necessitates more invasive surgical intervention, often a complex reconstruction like a hepatocujuginostomy.
So even a partial injury needs close watching.
Absolutely. Early detection and proper drainage are absolutely key to preventing these chronic complications. And this really raises an important point for you, the clinician listening.
Right.
Even a partial injury demands long-term vigilance because of that potential for insidious stricture formation. It can be a silent but very serious long-term issue.
What's the sort of window of opportunity we have, or maybe often miss, before that silent stricture really becomes a life-altering problem for the patient? Is it months?
Yeah.
Years?
It can vary quite a bit, honestly. Sometimes it develops within months. Other times it can take years to become clinically apparent with jaundice or cholangitis. That's why long-term follow-up, even after seemingly successful initial management of a partial injury, is so important. You can't just assume everything's fine after a few weeks.
That's a powerful point. The long-term threat of a stricture from what might seem like a minor lateral injury really underscores the need for that vigilance.
Okay, let's brace ourselves now for type E. This is the big one, right? The category that truly expands our understanding beyond the older classifications like bismuth and where the surgical intricacies really ramp up. Walk us through why type E is so much more complex.
Indeed. Type E basically encompasses complete transection or significant stricture of the major bile ducts, typically the common hepatic duct or the main right or left hepatic ducts. And it's subdivided into 5 variants, E1 through E5. And these subdivisions are based crucially on their relation to the hepatic duct bifurcation. That's the confluence, where the main right and left ducts join. Knowing the level of injury relative to the confluence is absolutely critical for planning the surgical repair.
Okay, so let's break down those subtypes. E1. E1 is a transection that happens more than 2 centimeters below the confluence. So you've injured the common hepatic duct, but you still have a good length of healthy duct remaining above the injury, below where the right and left ducts join.
And the implication?
The clinical implication here is that having more than 2 centimeters of remnant common hepatic duct generally allows for a longer, perhaps more forgiving segment for surgical anastomosis. It makes the repair comparatively easier, technically speaking.
Okay. Makes sense. What about E2?
E2 involves a transection that's less than 2 centimeters from the confluence, so the injury is higher up, closer to where the ducts split.
Uh-oh. Less duct to work with.
Exactly. The shorter duct remnant significantly complicates the repair. There's just less healthy tissue to suture to, and it inherently increases the risk of developing strictures after the reconstruction. It's technically more demanding.
Right. Then E3.
E3 describes an injury that occurs right at the hepatic duct confluence itself. The key feature here, though, is that communication between the left and right ducts is still preserved. The confluence is damaged, but not completely obliterated or separated.
So, still connected, but injured at the junction.
Precisely. This still requires a complex repair, often involving suturing the jejunum up to the open confluence, but the fact that both lobes remain connected simplifies the drainage aspect somewhat.
Okay. And E4. Sounds like it gets worse.
E4 signifies an injury at or even above the confluence that completely separates the right and left hepatic ducts. They are no longer communicating.
Oh, wow. So two separate systems now.
Essentially, yes. This means each lobe or major sections of the liver now drain separately. This necessitates a highly complex reconstruction, often involving multiple anastomoses. You might need to create two separate drainage pathways by joining the jejunum independently to both the right and left duct openings. Very challenging.
I can imagine. And finally, E5.
And finally, E5. This is often considered the most surgically challenging scenario. It involves an injury to the confluence area, similar to E3 or E4, plus an associated injury to an aberrant right sectoral duct, often the one that drains the right posterior section.
So a double whammy. Main duct and an aberrant duct injury.
Exactly. It's a dual injury involving both the main plumbing and an accessory duct, representing perhaps the highest level of surgical complexity due to the multifocal nature of the damage. You have to address both injuries adequately.
Okay. So thinking about type E injuries, generally E1 through E5, what are the overall clinical implications? How do these patients typically present?
The general clinical implications for all type E injuries are, as you'd expect, quite severe. Early presentation can be dramatic acute bile peritonitis if there's a leak, persistent high-volume drainage from surgical drains, or maybe rapidly developing obstructive jaundice that sends patients straight to the emergency room.
And late presentations.
Late presentations are unfortunately common too, especially if the injury wasn't recognized initially or maybe if an initial repair attempt failed. These are far more dire. Patients can develop chronic, debilitating biliary cirrhosis from long-standing obstruction, recurrent episodes of cholangitis, sometimes leading to life-threatening sepsis, and secondary biliary strictures that become incredibly difficult to manage over time.
So the therapeutic challenges must be substantial.
Absolutely. Type E injuries almost always require major biliary reconstruction, typically that Roux-en-Y hepatico-jejunostomy we mentioned. And as you know, that's a significant undertaking requiring specialized expertise. It's not an operation for the occasional biliary surgeon.
Right.
What's more, those injuries close to the liver hilum, particularly E2 through E5, are much harder to repair successfully and carry a higher inherent risk of restricturing after the operation. And a critical point that's often overlooked or maybe underappreciated is the very real risk of a concomitant vascular injury happening at the same time as the bile duct injury.
You mean damage to the hepatic artery or portal vein?
Exactly. Those structures run right alongside the bile ducts in the porta hepatis. An injury to the hepatic artery or portal vein can significantly worsen the overall prognosis. It can complicate the reconstructive effort immensely and sometimes even lead to liver ischemia, necrosis, or outright liver failure. It adds another layer of massive complexity.
Wow. So the prognosis really hinges on a lot of factors.
It really does. For type E injuries, morbidity and mortality increase directly with the complexity of the injury higher E number, generally worse, and crucially, with any delay in diagnosis and definitive intervention by experts. Getting good, retrievable outcomes is highly dependent on surgical expertise and vitally timely referral to specialized high-volume centers equipped to handle such complex repairs.
So to sort of distill this for our listeners, it really sounds like we've got a pretty clear management paradigm emerging here.
Yeah.
The minor injuries, let's say types A through maybe D, often lean towards minimally invasive or endoscopic strategies first, or maybe simpler repairs if needed.
Generally, yes.
But the major injuries, type E, almost always demand complex reconstructive surgery, probably best done in specialized centers, and definitely requiring multidisciplinary care. That's truly the fork in the road for management, isn't it?
It absolutely is. And for our listeners, that distinction is truly the fork in the road for management. Delayed diagnosis in these complex type E cases drastically increases the risks of sepsis, irreversible strictures, and that long-term liver dysfunction we talked about, making a bad situation potentially catastrophic.
Yeah.
This really underscores why early referral to centers experienced in complex biliary surgery significantly improves patient outcomes. A standardized classification system like Strasberg isn't just, academic box ticking.
Right, it's practical.
It's incredibly practical. It's invaluable for facilitating research, for training new surgeons effectively, for clear communication among healthcare professionals, whether they're across the hall or across the globe, and ultimately for establishing optimal patient care pathways. It gets everyone speaking the same language.
That brings us nicely to the actual decision-making algorithm in clinical practice. This is where the rubber meets the road for you, the surgeon listening. How do we apply this Strasberg framework when a patient actually presents with a suspected injury post-op?
Yeah, it's a structured approach, or it should be. It starts, as you said earlier, with high clinical suspicion. You've got to be looking for those post-operative symptoms, unexplained fever, worsening abdominal pain, maybe bile-stained fluid coming from drains, or the development of jaundice. Any of those should raise a red flag.
Okay, suspicion first, then what?
Then, of course, imaging is your next crucial tool. You need to visualize the biliary tree. That can range from a bedside ultrasound for an initial look, maybe for fluid collections, to a more definitive CT scan, or often an MRCP, that's magnetic resonance cholangiopancreatography.
Right, the non-invasive MRI of the bile ducts.
Exactly. Or sometimes an ERCP, which is invasive but can be both diagnostic and potentially therapeutic, like we discussed for type A. The goal of imaging is to accurately map out the biliary anatomy and precisely locate the injury if possible. Once you have that imaging in hand, the next critical step is the assessment and classification. You'll classify the injury meticulously, according to Strasberg. Why is doing the classification step so immediately actionable?
Because this classification, once you've made it based on the imaging and clinical picture, it not only helps predict the likely complications, but it immediately helps in selecting the most appropriate management strategy. It's not just a label, it's a guide to action.
It tells you which path to take.
Exactly. Knowing it's a type A versus, say, a type E dramatically changes your immediate next steps and the urgency.
Okay.
And this leads directly to management. The path forward differs significantly based on the type. Minor leaks, like type A, might get that endoscopic stent, or perhaps even just conservative treatment with careful drain management and monitoring. Isolated segmental duct injuries, types B and C, usually call for early repair if there are persistent leaks or signs of obstruction. Often this involves a surgical approach, although sometimes endoscopic or percutaneous methods are tried first to stabilize things or control a leak before definitive surgical repair. Right. And this is key for the major injuries. Types D, and especially type E, prompt surgical consultation with a hepatobiliary specialist and planning for early biliary reconstruction are absolutely critical. And here's a strong word of caution, really, for all clinicians involved. Try to avoid repeated, unsuccessful surgical attempts by non-specialists.
The redo operations are always harder.
Much harder. These complex type E injuries are best handled from the outset, or as early as possible, by those with specialized hepatobiliary expertise, typically in high-volume centers. The outcomes are demonstrably better when experienced teams manage these complex cases.
And it doesn't just end with the surgery, does it? After the initial management, long-term surveillance is absolutely essential. What are we specifically watching for, and what else should surgeons be considering in the overall patient journey after a bile duct injury? That's right. The journey often continues long after discharge. We're primarily watching for potential long-term complications like the recurrence or development of biliary strictures, the progression of any underlying liver damage towards cirrhosis, and recurrent episodes of cholangitis. These patients often require years of follow-up, sometimes with periodic imaging or liver function tests.
And beyond the medical surveillance.
And beyond the strictly medical, let's not forget the crucial aspects of psychosocial support for the patient and their family. These injuries can be truly devastating. They can lead to multiple surgeries, prolonged hospital stays, chronic symptoms, and have a significant negative impact on quality of life. Acknowledging that and providing support is vital.
Absolutely.
And of course, underpinning everything is thorough, informed consent for all surgical interventions, especially the complex reconstructions. Patients need to understand the significant implications, the risks, and the potential for chronic issues down the road.
Okay, wow. We've certainly unpacked a lot today. Hopefully you listening can now see how the Strasberg classification isn't just some academic list, but really a fundamental living roadmap for navigating the complexities of bile duct injuries. Its consistent and meticulous use enables tailored, evidence-based interventions, which is just paramount in modern surgical practice, wouldn't you say?
Indeed. I think the continued education of all surgical professionals, maintaining meticulous surgical technique during the initial operation, and perhaps most importantly, prompt recognition of an injury when it occurs. These remain absolutely essential in preventing serious morbidity. And, as we've emphasized, equally important is that timely referral to hepatobiliary experts for definitive management, especially for those severe type E injuries. Understanding and applying this classification is truly invaluable for all surgeons and clinicians involved in managing biliary tract disease. It's not just about knowing the types, but really knowing the implications and the right path forward for the patient.
Absolutely. So beyond the meticulous classification and the complex surgical techniques we've discussed today, let's leave our listeners with something to think about. Consider this. What are the most critical non-technical skills? Maybe things like communication within the surgical team, or decision-making under intense pressure in the OR, or perhaps that early recognition of subtle, often non-specific signs postoperatively that you, as a surgeon or clinician, rely on most heavily in preventing and managing these challenging bile duct injuries in your own daily practice.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.